Hello, good evening once again. Um,
Even
can you hear me?
yes, I can hear you.
Uh, yeah, so it's another Sunday and we're going to have another AfroDx unknown case presentation. Um, I think David is ready to solve yet another case. So, David, because we have had a one liner opening for some time now, I think I'll go first and include the HPI and you discuss both of them together. And for today, we have a 74 female who presented to the hospital I'm working with fever and altered mentation. And so it will be in a couple of days. So I'll start with day one when she presented. And the relatives report that she told them she was feeling unwell and decided to go to sleep. It was like 2 p.m. And when she woke up, they realized that she was speaking irrelevant words. And the caretaker reports that she also had fevers when she woke up, and she was sweating profusely. Um, and so they decided to bring her to the hospital I was working. And she also had one episode of vomiting. She vomited recently eaten material, but she denied any convulsions, loss of consciousness, headache, cough, shortness of breath, chest pain, nasal congestion, sore throat, diarrhea, constipation, abdominal pain, dysuria, urinary frequency, abnormal PV discharge. She all denied these, and that's a short HPI for day one.
Okay, so this is interesting, and I think I'll try and tackle it the way you presented it. So we have a 74 years old female presenting with a 1 day history, I believe. Yes, so initially of fever and altered mental state. Yeah, so I think both of the complaints, those are two complaints in one. So fever, I think we've talked about fever many times. And then, so this patient is presenting with fever and altered mentation. Altered mentation, the number of differentials, we have so many differentials. So what I'll try and do, these can be so commonly what we like to do is to think of one pathology that can explain both complaints. And that could be the case in this patient, or it could be that there are two different pathologies causing two different complaints. But then what we try to do is to find the point of overlap between these two complaints. So we talk of fever, we think about infections, malignancy, autoimmune disease, drugs, endocrine causes. But then when you think of altered mentation, there's a thousand of things that can cause that. So the points of overlap are like, especially in this patient in whom we're talking about uh, an acute presentation of fever and then or fever and altered mentation. So infection is one of those. But then uh, we see, especially the last bullet, I think has not reported many associated symptoms, which would make us think of an infection as a cause of this. So, for example, meningitis can present with fever and altered mentation, encephalitis. So you think about infections in the central nervous system particularly, but then something like cerebral malaria can also present the same way. So basically, I think I would prioritize infections based on the acuity of the symptoms and based on the base rate. But again, yes, there are some other things, of course, which we can also think about. So, for example, if I try to think about, I'll try as we proceed to think about anything endocrine, for example, that can explain both fever and altered mentation. So, but at this point in time, I think I'm thinking more about infections. But then just to try and expand my differentials a little bit, I'm thinking this patient went to sleep in the afternoon, I believe. She was well. I mean, she was feeling unwell, not very clear what exactly she was feeling, but then she went to sleep and she wakes up, she's confused, and then she has fever. So uh, so this has happened over a matter of hours. It has happened over a matter of hours. So I think as much as I try to think about infections and maybe other things that can explain inflammation in general, but involving the neurological, the central nervous system, I should also try and think about other possibilities. So, for example, this may be very far-fetched and rare, but this could be a rare presentation, for example, of a vascular event presenting with confusion and altered mentation. But then I think that is far-fetched and it's very esoteric. So I'll try and think about the commonest things first before I consider that possibility. So any more details that you have?
Okay. On the same day one. So reproductive system only musculoskeletal that she complained of chronic low back pain and also chronic bilateral knee pain. Past medical history, she has chronic low back pain, she has a bilateral knee osteoarthritis, she's hypertensive, and she has dyslipidemia. Here are meds that she's on amlodipine, atorvastatin, clopidogrel, meloxicam, and joint support. And family and social history, she's a homemaker, she has several children, adult children who are healthy, and she is a non-smoker, she doesn't drink alcohol.
Okay, so nothing very significant. I mean, except I talked about one very far-fetched possibility. So this patient is hypertensive. She has dyslipidemia. Those are risk factors for a cerebrovascular event. She's on. Can I see the medications again?
Okay.
Okay, amlodipine, atorvastatin, clopidogrel, meloxicam, joint support. So I believe she has been on these medications for quite some time now, because just to explore all possibilities, someone who presents with a fever, one possibility is someone can present with fever as a drug reaction. So we discuss the case of dress here, a drug reaction with eosinophilic and systemic symptoms. So uh, drugs can cause that. But then what we are thinking of, this patient has probably been on these medications for quite some time, and therefore to say that she's having a drug reaction now, uh, that may not be, that is a far-fetched possibility. This patient has osteoarthritis, or the NSA, the meloxicam, is because of due to the osteoarthritis. Joint support, which is glucosamine and chondroitin, and then we see amlodipine, atorvastatin, clopidogrel. Drug reactions are possible with virtually most drugs, but then my assumption is she has been on these drugs for a long time, and therefore the possibility of a drug reaction is probably far-fetched. But then the history of hypertension, I think we are not sure how much controlled is the hypertension, but then that the hypertension and the dyslipidemia, those could be a risk factor for a CVA, which is a far-fetched possibility in this patient. So that is what I gather from those other components of the history. So let's hear more. Importantly, this patient is, I do not see any features of immunosuppression. Yes, we mentioned that there is a possibility that we are talking about an infection involving the CNS. As we know that some infections can occur even in immunocompetent patients, but then some infections commonly occur in immunocompromised patients. We do not see any features of immunosuppression like diabetes or anything else. So I think that's another thing that I needed to tell myself. So can I see other? any other details that you have.
So on exam, on the day that she presented, she was an obese elderly woman. She was confused. She was febrile. She was not pale. She was not jaundiced. She had bilateral impinging edema. She had no peripheral lymphadenopathy. Her vitals, she had a hypotension of 83 over 53 and tachycardic at 112. Also, she was febrile at 38.9, but she was saturating normally on room air. Systemic exam, only musculoskeletal that was had findings. She had tender knees during flexion or extension, and but no swelling, no warmth, no erythema on those knees. Chest, abdomen, cardiovascular neuro were all unremarkable.
Okay, a number of things to unpack here. So the patient is confused and is febrile, of course, in keeping with the history that the patient presented with fever and altered mentation. She's not pale, not jaundiced. So what's interesting is this patient has bilateral lower limb edema. A number of possibilities here. I'm thinking, what is causing this lower limb edema? Could it be uh, one of those patients who develop lower limb edema when they use amlodipine? That could be a possibility. But then, what else are we dealing with? So, in the history, as well as the physical examination, we do not pick anything that suggests that this patient has heart failure or whether this patient has any renal insufficiency, although maybe, yes, I mean, that maybe would not be very apparent, at least at this point, but then we would expect, at least from the history, to hear things like, is there reduced urine output or something like that? So one possibility could be that the lower limb swelling is because of the amlodipine, but then I'll try and see if it connects to this patient's presentation, because at least at the moment I do not see any connection with heart failure or renal insufficiency in this patient. But then the vitals are making me think of something. So I think we can, up to this point in time, we can have a presumptive diagnosis of sepsis. Why? Because this patient uh, is confused. So the GCS would be something like 14, 14 over 15. So that is already altered mentation. And then this patient is hypotensive. That systolic blood pressure is less than 90. And of course, we talk about less than 100 when we deal with sepsis. So that is 2 out of 3 in the QSOFA criteria where we have we talk about hypotension, altered mentation with a GCS of 14 or less. Another thing is tachypnea. So when you have a respiratory rate of more than 22, we do not have that one in this patient. But so I think uh, we should consider a possibility that we are dealing with sepsis in this patient. But now when we talk about sepsis, at least up to this moment, I have not been able to find a focus of infection because we did not hear anything coming from the respiratory system, coming from the skin and soft tissues, coming from the genitourinary system, or from the GIT. We have not had anything of that sort. So, but I think with the limited information that we have up to this point, I think one of the things that I'll consider in this patient is that we're probably dealing with sepsis. But then another thing is this patient is tachycardic, and that tachycardia, I think one of the things that can explain it is the fever. We already talked about this in previous sessions that when you have fever, we expect the pulse rate to increase. So that tachycardia could be explained by the fever, or it could also be explained by the underlying process. For example, maybe the infection that is going on. So those are the possibilities I'm having at this point. But then uh, the systemic examination, the findings on the knee. So I think yes, with osteoarthritis, with joint movement, we expect pain. But then we are told they are not erythematous, they are not swollen. So a possibility that we are dealing with infective arthritis, for example, I think it's less likely. And in the systemic examination, I have not been able to pinpoint or to localize any focus of infection, at least as it has been presented up to this point. So I'm thinking that this patient, as we said, we are probably dealing with an infectious cause. And with this physical examination, I think sepsis is something that we have to think about. And I'm also, so I talked about a possibility of something like a CVA, but then the neurological examination, I believe, as you presented, was non-localizing. There are no focal neurological deficits. So we'll see. Let me get some more details and see if I can make progress.
So here are the labs, and they're quite impressive. So MRDT was negative, white count highly elevated 21, is neutrophil predominant of 19. HB was normal, platelet was normal, creatinine urea normal. AST was 415, ALT was 193. So these two, when we checked in the system, she had them a year ago, which were also elevated, but not this much. They were like twice the upper limit of these normal. And bilirubin total and direct were normal. LP elevated at 88, GGT elevated at 51, RBG was normal, uric acid also slightly elevated 471, CRP elevated 48. Analysis only showed a leukocyte plus 1. Hepatitis B surface antigen, hepatitis C antibody HIV, negative. That's it.
Okay. Okay. This is uh, I'm trying to think what are we dealing with here. So these labs, we see a predominantly neutrophilic leukocytosis, which could be anything, But based on our patient's presentation, yes, an infection is a possibility. But this is one thing that I try not to make premature closure, because I see it has also been common practice that when many practitioners see leukocytosis, they say this patient has septicemia. Not sure if that is exactly right. So an elevated leukocyte count can be due to anything. Yes, commonly an infection, but you can have an elevated leukocyte count as a result of maybe this patient is using steroids. Uh, and then you can also have an elevated WBC count from some malignancy. So there is a number of possibilities. So now what is striking here is the transaminitis that we see, and so there is so AST ALT highly elevated. So especially if you look at the ALT, for example, that is more than 3 times the upper limit of normal. And then we also see that ALP and GGT are also elevated. So you basically have a mixed pattern that is cholestatic as well as uh, and I mean hepatitis. So you see, it's not just hepatitis, but there is also not just hepatocellular but also cholestatic. So it's a mixed pattern. And uric acid CRP. So what the CRP tells me is that we are dealing with inflammation. The question is, what is this inflammation? So inflammation, infections, autoimmune malignancy. But then you told me that the ASD and the ALT about a year earlier were this way, but it has been higher this time. So I'm thinking, I think I'll try to throw a number of possibilities. So, for example, um, With this picture that we see, of course, there is a hepatocellular injury. So with the hepatocellular injury, the question is what is going on? The hepatitis viruses are negative, but of course you can have hepatitis from viruses other than these hepatotropic viruses that we know, hepatitis B and C. You can also have hepatitis from bacteria, from fungi, and from many other things. But another possibility, although this is an old lady, 74 years old, but then I think we can also consider a possibility that we are dealing with autoimmune hepatitis because of this hepatitic picture that we see here. But another possibility that I think would not exactly explain the hepatocellular injury, but would explain uh, the more of a cholestatic pattern is, for example, but this patient is not jaundiced. I think that is one of the things that makes what I'm thinking about less likely. But ascending cholangitis, presents with what we call a Raynaud's pentad, I believe. So uh, you have fever, you have all these features of sepsis, and then you also have altered mentation. So is there a possibility that we are dealing with cholangitis? I think that is another thing that I need to think about in this patient, especially with the high grade fever, the confusion, and the vitals that we see. There is a possibility that we are dealing with cholangitis. But then the hepatocellular injury, I mean, cholangitis by itself, I would not expect it to present with this very pronounced hepatocellular pattern. So I'm thinking what is causing the transaminitis. So maybe I think I should also try to think about autoimmune causes, autoimmune hepatitis being one of the possibilities, and the other conditions, of course, because there is involvement also the biliary system possibly. So primary biliary cirrhosis or primary sclerosing cholangitis, but then at least from the history, we did not have anything that is in keeping with those. So I think a number of possibilities, and I think, frankly, lost at this point in time, but maybe we can make progress if you have any other details.
Yeah. So that's how day one ended, and it was my fellow doctor who was on call that took care of that day one. So if you are you now, you have all those information. What's your diagnosis and how do you treat her?
Okay, so on day one, what I would do is we have a 74 years old female, uh, known patient with hypertension and bilateral knee osteoarthritis with chronic lower back pain, on some medications as we've seen, amlodipine, atorvastatin, clopidogrel, meloxicam, as well as joint supplements. She presented with a one-day history of fever and altered mentation, no localizing symptoms, at least from the history. And then on physical examination, the patient is altered, hypotensive, tachycardic, and febrile. So labs, we see leukocytosis with predominant neutrophilia. We see elevated inflammatory markers, CRP, and we see a picture of hepatocellular as well as cholestatic pattern. However, hepatitis virus screening was negative. So I think with all the confusion that I have, because sepsis, if not treated, sepsis is fatal. I mean, the mortality without intervention is very high. So I would make a presumptive diagnosis of sepsis. And so with the information that I have, I think to a big extent I might be wrong, but then I would think that cholangitis is probably the cause of this patient's sepsis. So I will treat this patient as a patient with sepsis. So with the blood pressure that we saw, I will keep this patient on IV fluids, uh, and I'll also keep this patient on on broad spectrum antibiotics. So, for example, if I'm thinking about a possibility of cholangitis, so I think I would need to cover with something strong like piperacillin tazobactam. So, uh, fluids and monitor closely response to the fluids, because I want that blood pressure. That blood pressure to be, I believe, if I calculate the map there, it's probably less than 65. So I want to keep the mean arterial pressure above 65. So I'll give this patient fluids and I'll cover the patient with broad spectrum antibiotics. And at the same time, of course, I'll take, before giving antibiotics, I'll take samples for blood culture. That is what I will do for this patient.
Yeah, that's what everyone would do. But two questions arises from the fellow doctor that what kind of antibiotics, and then is there a possibility that someone can never cholangitis without the right upper quadrant pain?
Okay, that's those are interesting questions. Whether someone can have cholangitis without upper quadrant pain, I think a reflex answer would be no. But then anything can happen in medicine. So especially because we are talking of cholangitis rather than just cholecystitis, or there's a difference between the two. So for cholecystitis, someone, I mean, commonly they would complain of right upper quadrant pain, and then on examination, Murphy sign would probably be positive for cholecystitis. But then for cholangitis, I think it is a possibility. Although yes, I would need to go back to books and see. But then I think someone with high grade fevers and then confusion, even without right upper quadrant pain, I think I would still need to consider cholangitis. And the kinds of antibiotics that you need to cover. So with cholangitis, I know that intestinal anaerobes are also a possibility. So you need to cover with those. But as far as I remember, treatments for cholecystitis and cholangitis, anything that contains a beta lactam, especially something like ampicillin, is fine. So piperacillin tazobactam, I think piperacillin tazobactam is broad enough, I believe. But so for patients who are high risk, which we've not seen in this patient a history of an admission in the past 90 days, I think any broad spectrum antibiotics who would need more than one strong antibiotics. We have not seen that in this patient. So, and of course, I think I'll have to review my critical care medicine, but I think piperacillin tazobactam would be fine.
Sure. So let's move on. First, for so yes, as you said, the attending doctor started the patient with IV fluids because of the insurance issues. You have to start with low antibiotics, that is subjective metronidazole and paracetamol. And day two, confusion resolved, blood pressure stabilized, but patient is still febrile at 38 degrees centigrade, but there are no new symptoms. So I came in day two and I told them, let's repeat MRDT. It came back negative. Let's do chest x-ray. Maybe there is something we can see, but it was normal. We also ordered abdominopelvic ultrasound, only show hepatomegaly of 17 centimeter, and we do blood for culture and also urine for culture, and that was used for day two. Are you doing anything else in day two?
Okay, so with this additional information that we have, so I mean, sometimes treatment is part of making a diagnosis. So you are giving this patient fluids and the confusion results. So there is a possibility that, a possibility that we are dealing with sepsis. Uh, at least we become more confident that there is a possibility that we are dealing with sepsis. So confusion resolving, so right from the beginning, a diagnosis of sepsis, I believe, was very reasonable. But then this patient is still febrile. So, and a patient with a fever like this, there is a huge possibility that there is a deep-seated focus of infection an intra-abdominal process being one of those. So whether it's an abscess somewhere, but also I think among the common causes in situations like those, still a possibility of cholangitis. Yes, ceftriaxone and metronidazole, I think they are good enough empirically, but then I mean, maybe for something like cholangitis would need something stronger. But then, of course, I'll need to review my school on that. And then I think again the septic screening meticulously done, MRDT negative, once again a chest X-ray, which reduces the possibility that our focus is in the respiratory system. But then another addition of confusion is on ultrasound, abdominal pelvic ultrasound with hepatomegaly, no other findings. So we ask ourselves, what is the cause of this hepatomegaly? I think I've not been able to answer that question. So with the progress that we've made, I think what we need to do at this point is make a case to switch the patient to broader spectrum antibiotics while waiting for culture results, and of course take additional cultures, because in order to increase your confidence that maybe a certain organism is what is explaining the presentation, then we would need a number of culture bottles in order to conclude. So I think take more culture, but then make a case and keep this patient on a broader spectrum antibiotics while looking for the possible explanation.
Yeah, that's good. Can you summarize the case too? I think a lot of people have joined late.
Okay, so Joseph has been presenting a 74 years old female, known patient with hypertension and bilateral knee osteoarthritis and chronic lower back pain. This patient is on amlodipine, atorvastatin, clopidogrel, meloxicam, and joint support. The patient presented with a one-day history of fever and altered mental status. On physical examination, she was confused, uh, febrile with a temperature of 38.9, and the patient was hypotensive with a systolic blood pressure in the 80s, 83, I think, to 50 something, 59. And the pulse rate was 112, but she was saturating well on room air. So labs revealed leukocytosis with predominant neutrophilia, elevated CRP, but with a picture of hepatocellular injury as well as a cholestatic picture. So we have ALT elevated more than 3 times the upper limit of normal, and AST also elevated, but we also have an elevation in the ELP as well as GGT. So this patient was initially kept on ceftriaxone and metronidazole and IV fluids. Confusion has resolved, but the patient is still febrile, and ultrasound reveals hepatomegaly.
Yeah, uh, thank you very much. That's a very good summary. So before we proceed, I think I should applaud you because, you know, if someone is not keen enough, you can end up saying sepsis and you end up there. It's just like saying anemia, but you are struggling trying to find the source because if the source is the chest, maybe the antibiotics are not going to be the same as if the source is a GI. So that's very good. Um, so if I tell you what happened to day 3, the diagnosis will become very clear. But can you guess, like, are we going to, what source are we going to find? 2 days, and then the source can reveal itself on day 3.
So the source of this sepsis. So I'm convinced. So with the history that we have, I do not see any focus in the integumentary system, meaning the skin, also the soft tissues. We did not see anything there. The chest, nothing. Of course, we had something in the urine, leukocytes +1, but then I'm always careful, especially with older ladies. I mean, you can have what we call asymptomatic pyuria. So this patient is not having any urinary symptoms like dysuria, but then you do a urinalysis and you see actually numerous leukocytes. So I think I'll be very reserved, not to say that probably the source of this infection was the urinary tract, but then because we also took urine culture, I believe if that is the case, then we will be able to establish that. So I think the urinary system, I cannot say is not the source, but I think I'm reserved on that. So respiratory system, I think out. The integumentary system out. The urinary tract, I'm still having some reservations. So what I see here is most likely we're dealing with an intra-abdominal source, and that intra-abdominal source, I'm thinking most likely cholangitis. But then I'm still thinking, what is causing this hepatomegaly? I do not have an answer to that question. What is causing this transaminitis? I do not have an answer to that question yet. So I'm thinking the most likely source is probably intra-abdominal, likely cholangitis, but also the urinary tract could be a possibility, but I think very low on the list.
Yeah, that's very good. So it's very interesting. Internal medicine is very interesting. So day three, we came to round, and she still spiked fevers. But on that day, she told us something else. She said she had osteoarthritis. Her knees were painful since day one. But on day three, she said she feels like her right lower limb is more painful than her left lower limb is more painful than the right lower limb. And when we examined the limb, we found that it was swollen, warm, and tender. We sent her for Doppler. It ruled out DVT. I think now it's clear.
Yeah, so with this one, I would say so. The leg was swollen, warm, and tender. So so that would I would say that is probably cellulitis. Cellulitis, which was of course on day one we did not. There was nothing like this. So the patient had pain on both knees, especially on movement, which we attributed to osteoarthritis. So now something new comes. We are probably dealing with cellulitis, which could explain the sepsis. Yes.
Sure. So, true. We had also diagnosis of cellulitis of the left leg. We thought since she's obese, the transaminitis was because of non-alcoholic steatohepatitis, and that's the only thing that could explain because they were raised a year ago and they're still going up, and nothing else can explain a picture like that asymptomatic, which is the case. But we're still querying this. Maybe later there can be another cause. But are you like surprised cellulitis and you have 2 days of very bad sepsis? And it's until the third day in the ward that you are showing the symptom of the infected soft tissue. And what will be the treatment at this point?
So yeah, I'm definitely. I mean, as and maybe this is of course one of the reasons as to why we need to keep learning always in medicine, because I would say this is the first time where someone presents with, for example, cellulitis as a focus of infection, and then they come with sepsis, and then the source reveals itself late. I mean, this is uh, yeah, I believe the first time I hear, or yes, I get to witness something like this. So yes, I'm surprised. I'm surprised because with cellulitis, I would expect right on day one someone to come with a swollen limb, very tender, very erythematous, and then if they come with fevers and any other presentation, I wouldn't be surprised. But then it's like so something which starts from the end and then goes to the beginning. That's what I see here. So it's a surprise, and for something like for sepsis, I mean for cellulitis. So cellulitis, what I treat with commonly something like Yes, so you need, because with cellulitis, one of the commonest organisms are actually the organisms that we find in the skin. So, and something that causes bad sepsis like this one, I would need to be concerned about a possibility of staphylococcus, especially staph aureus. So, yes, if someone came with cellulitis which was uncomplicated, something like flucamox, so a combination of flucloxacillin and amoxicillin, uh, does quite a good job. Someone recovers from the cellulitis, but then the patients are septic. So yes, I would pick something of in the beta lactam group, but then because we also took culture, I'll be open to see the results in order to just to make sure that we are not dealing with something like MESA, methicillin resistant staph aureus, which would need now the big guns like vancomycin
Sure.
and other antibiotics. Yes. So I would still go with beta lactams, but wait for culture results.
Yeah, yeah, that's pretty good. Yeah, I was also very surprised. They said I've never seen this, but the reason I shared this because I also had seen two cases. I remember one was also septic, and then they came in the evening, confused, fever, and there was no source. We just gave antibiotics, but fortunately, on the next day in the ward, the patient started coughing and difficult breathing, did chest x-ray, it was in the morning. I said, oh, so it can start with fever and stuff, and then the other symptoms follow on the next day. And the other, I remember I've shared with you, David, um, it was the I think it was a skin lesion. Yeah, it was a zoster, but again, patient just came with pain on the loin. And you know, pain on the loin, I said two things: stone or pyonephritis. And then ultrasound was normal, urine was normal. Even did chest CT scan of the abdomen and no stone. And on the next day, the rash appeared. They said, okay. I was super surprised. But one thing I've realized is, we, and I think most people here, are trained on tertiary centers, and patient came in tertiary centers already, like they have a disease for some time, and you see the full picture of the disease. But if you have a first encounter of patients, some things can be difficult, and maybe they don't make sense. And what I've learned is just to be honest that you don't know, and you keep on searching. So uh, I read a paper about this thing, and there was a saying that when seeing patient first encounters, time is also a diagnostic tool. Like you say, I don't know what's going on here. This patient has sepsis. We should do broad spectrum antibiotics that will cover maybe all sources, and then we give it time. Maybe it will come up, or do some more investigations. For example, if there was nothing on this day, we were planning to go to the direction that David you are saying. Maybe there is a focus, or a pus focus inside the abdomen or chest. Probably we should have done pan CT to this patient, but luckily on that third day, psoriasis came up. So a bit on this disease, we all know it's an infection of the skin or soft tissues. The diagnosis is pretty clinical. You see edema, pain, swelling, and warmth. So systemic symptoms can precede local inflammation for minutes or hours. This is written in the literature, but I've never seen that they count the hours, and they didn't say days. This is the maybe uh, I don't know, like very unusual. They say minute to hours, yes, and I've seen people with cellulitis when in the morning they have fever, malaise, and stuff, and in the evening they start having pain, and then they come to hospital. But coming to hospital is sepsis, and then sitting there 30 days and then showing the local inflammation. Pretty unusual. So strep pyogenes is the most common cause. If you see purulence on the limb, also think of staphylococcus. Treatment will depend on was if patients have sepsis or not. If they have sepsis, you do like big guns of antibiotics, give vancomycin. That's what we're giving this patient right now. And if there's no sepsis, you can give cephalexin. That's easily available, but the only problem will be it need a QID dose. So imagine 6 hourly. It's very difficult, and it requires someone that can take orally. You can also give decloxacillin, cloxacillin, clindamycin, cefazolin. Yeah, reflection, David.
Thank you very much, Joseph, for the case. Yeah, so I mean, this is the beauty of medicine, and something that humbles us every time. So you see a case, and one thing I love about the clinical unknowns is, yes, I mean, you have already done, and maybe that is one reason I most of the times I either get the diagnosis right or I come close to the diagnosis, because at least you've digested a lot of things for me already. But then there's still a lot of uncertainty. So, for example, for this particular patient, fever, altered mental status, I think it would have. So it takes you to the CNS, for example, thinking about things like meningitis, but then you come to physical examination, neuro exam is normal, no signs of meningeal irritation. You think what else is going on? So I think again putting things in totality. So taking the history, taking the physical exam. So for example, for me, I think what was helpful to come close to the diagnosis were the vitals. I was still confused what exactly is going on, but when it came to the vitals, I see this patient is hypotensive, this patient has altered mental status. Then I think, okay, so sepsis, but then what is the cause of this? I mean, what is the focus of infection? That was the next question. And so, yes, I think this was a good learning opportunity for me. I think I also have things to go and review about, because, and again, that is new knowledge added, that you see someone presenting with full-blown sepsis, and then the focus of infection presents itself later. So I think that was the biggest takeaway for me today. Thank you very much.
Yeah, even for me. Yeah, thank you, Roland, for the question. I think David, you can. Do you see the question?
Okay, let me see the chat. Yeah, so this is an interesting question, and quite frankly, I'm not sure if I have the answer. I'm still thinking what could be the cause with the elevation, because now we are talking about this patient is having hepatitis, and the especially the ELT is more than 3 times the upper limit of normal. But again, we see the GGT, the ELP also elevated. Now I'm thinking, like you said, Joseph, that probably non-alcoholic steatohepatitis, because the hepatotropic viruses, which of course are one of the commonest causes of hepatitis that we know, were negative. Hepatitis B, C negative. This patient has not. The patient has not been drinking. Is a lifetime. She has never been drinking, so we would not implicate alcohol. Of course, when we talk about sepsis, end organ damage as a result of sepsis can affect any organ system, including the liver and biliary system.
Exactly.
But then with that one, of course, we would look at other things. So, for example, in the SOFA, the comprehensive SOFA, because I discussed the Q SOFA in this case, in comprehensive SOFA. So as far as the biliary and the liver and the GIT in general are concerned, I think they use bilirubin direct and total. So bilirubin direct and total were normal in this patient, but there is transaminitis and a cholestatic picture. So I quite honestly do not have an answer or an explanation as to the cause of these patients. Transaminitis. So I think maybe a follow-up would be important, because if it is because of the sepsis, then we expect the transaminitis to resolve over a few days after treatment. And of course, another thing, statins are known to cause hepatitis. But then this is quite, and yes, I mean, that would be another possibility that we consider, because this patient is on atorvastatin, and statins are known to cause hepatitis. So statins can be an explanation. So I think we still need to find the cause of the transaminitis in this patient.
Sure.
Yes.
Yeah, that's a good answer. Yeah, thank you, Roland. And anyone else? Addition, question, ushauri. Okay, no one. So thank you guys for being here. We have learned quite a lot from David and the case. And see you next week. Have a good night.
Good night, everyone.